All right, so next we're looking at additional high-grade gliomas, but grade 3. This is histology and genetics. Histology, these are either astrocytomas or oligodendrogliomas. Classically, they were graded as per the Amen criteria. Grade 3 equals 2 of the 4 criteria. Then genetics, either IDH mutant or IDH wild type. Again, if it's mutated, then you look at 1p19 co-deleted or not. And going back up, just to show this, again, the new 2021 molecular classification looks at IDH mutant versus IDH wild type. If it's IDH wild type, it is automatically considered a GBM. If it's IDH 1 or 2 mutant, then the question again becomes 1p19q co-deleted or not. So this is a bit anachronistic at this point. IDH is an enzyme in the Krebs cycle. Chemo that you need to know for these grade 3 gliomas is PCV. One cycle is 6 weeks. P stands for procarbazine, PO, so it's by mouth. C is CCNU, which is lomustine, which is also by mouth. And V is for vincristine, which is IV. Again, pathology, look at 1p19q co-deletion status after looking at the IDH mutation. If it's co-deleted on fish, you will see 1 red and 1 green dot per cell as opposed to 2 of each. So that's a big key there. If you see 1 red dot and 1 green as opposed to 2 red dots and 2 green dots, that means you're looking at an oligodendroglioma. Again, IDH1 mutation status, mutants are more favorable for high-grade gliomas. The wild types are not considered GBMs. Both have better prognosis. 2/3 of grade 3 gliomas will enhance with contrast. Histologically, if we're looking at a grade 3 oligo or astro, then ask genetics, IDH wild type or mutant, if it's mutant, 1p19q co-deletion or not. Grade 2 and grade 3 IDH wild type diffuse astrocytomas are considered GBMs. And again, if they have EGFR amplification, chromosome 7 gain or 10 loss, TERT promoter mutation, they're classified as WHO grade 4 and should be defined as diffuse astrocytic glioma IDH wild type with molecular features of a GBM. For any IDH mutant, either 1p19q co-deleted, molecular oligo, or non-co-deleted molecular astro, the goal paradigm is going to be maximum safe resection, followed by external beam radiation, 59.4 at 1.8 grade per fraction, followed by adjuvant PCV times 6 cycles. This is EURTC. This is generally what's favored. Alternatively, the other option would be maximum safe resection, then chemo up front, PCV times 4, then external beam radiation, 59.5, 1.8 grade per fraction, RTOG. Alternatively, you can also consider treating these patients with concurrent and adjuvant temozolomide, a la Stoop. This is currently being tested versus PCV in the CODEL trial. Of note, CODEL uses radiation followed by PCV times 6. So you could prefer that as the ideal instead of PCV before radiation. Otherwise, if it's IDH wild type, it's a molecular GBM, which does not benefit from PCV, so you extrapolate from the Stoop data and you consider maximum safe resection, followed by EBRT, 59.4 at 1.8 grade per fraction, plus Temodar, followed by Temodar. In terms of trials I need to know, the first is RTOG 9402. This is Karen Cross, JCO 2014. This is look at anaplastic oligodendrogliomas. The addition of neoadjuvant PCV to radiation. I think of Karen Cross as a patrician blue bud, and thus this applies to AOs and AOAs. So astrocytoma and oligoastrocytoma. AOA is no longer in the WHO classification. These patients receive neoadjuvant PCV times 4, followed by radiation of 59.4 gray, versus radiation up front, 59.4 gray alone. So again, neoadjuvant PCV times 4 followed by 59.4 radiation versus 59.4 radiation alone for AOs, anaplastic oligodendrogliomas, and anaplastic oligodendroastrocytomas. The results from this neoadjuvant PCV doubled median overall survival for the IDH mutant 1p19q co-deleted, so only for the molecular oligo types, 14 years versus 7 years. Bottom line is neoadjuvant PCV improved progression-free survival and overall survival on an updated analysis in anaplastic oligodendrogliomas with one p19q co-deletion. One more time, RTOG 9402, Cairncross, JCO 2014, looking at anaplastic oligos and anaplastic oligoastrocytomas. The addition of neoadjuvant PCV to radiation. I think of Cairncross as a patrician blue blood, thus AO and AOA. 289 AO and AOA. Again, AOA no longer exists. They got neoadjuvant PCV times 4, followed by radiation to 59.4 gray versus just 59.4 gray alone. 59.4 gray neoadjuvantly doubled the median overall survival for the IDH mutant 1p19q co-deleted. So these are by definition molecular oligos from 7 years to 14 years. So it was really significant improvement. Bottom line there is neoadjuvant PCV improves progression-free survival and overall survival for molecular oligos. The next trial is EORTC 26951, Van de Bent JCO 2013, again looking at anaplastic oligodendrogliomas and anaplastic oligoastrocytomas. These patients were randomized to maximum safe resection followed by radiation plus PCV times 6 cycles or just radiation. So maximum safe resection, radiation followed by PCV times 6 cycles versus maximum safe resection followed by radiation. Overall survival was improved with PCV for IDH mutant 1p19q co-deleted. Again, molecular oligos. Median overall survival, 9.3 years, was not reached. Subset analysis for RTOG 9402 for the Cairncross study showed benefit as well for IDH mutant 1p19q non-co-deleted tumors. Only the IDH wild-type non-co-deleted, which are essentially molecular GBMs, didn't benefit. Both trials here use 59.4 for radiation. Catnon trial is also Van de Bent. This is published recently in 2021. This is looking at the addition of Temodar to anaplastic gliomas without 1p19q co-deletion. So anything that's a anaplastic glioma that's not an oligodendroglioma molecularly. Again, Catnon study, kind of extrapolating from Stoop here. So we're getting radiation alone, 59.4, versus radiation with concurrent Temodar, versus radiation with adjuvant Temodar, versus radiation with concurrent and adjuvant Temodar. Bottom line, overall survival benefit for adjuvant Temodar and IDH mutant, but not IDH wild type. No benefit to concurrent Temodar, either by itself or together with adjuvant Temodar. The CODEL trial, again, is ongoing, which is comparing PCV and Temodar. But the Catnon trial, again, is looking at the addition of Temodar to anaplastic gliomas without that 1p19q co-deletion. Volumes and doses, again, you want to use the post-op imaging, do the same expansions as you do for GBM. The initial cavity is 50.4 as opposed to 46. This is the cavity plus the T1 enhancing area plus the T2 flare. And you do 2 centimeter expansion on that to get your CTV 50.4. Your PTV is simply a 5 millimeter expansion from that. Your boost to 59.4 gray is the cavity plus, again, just the T1 enhancement. That's 2 centimeter expansion and 5 millimeter expansion on that to form your PTV for your boost. We already talked about the constraints. Median overall survival for oligos, IDH mutant 1p19q co-deleted is 14 years. For astrocytomas, it's about 6 years. For IDH wild type, it's 2 years, which are molecular GBMs. Follow-up MRI at 1 month, then every 2 months for 3 years, then every 6 months thereafter.